Oh, there we go. Okay, thanks. All right, logistics, start on time. Oh, well, close enough. We'll try and stop on time. I don't know that we have a huge crowd, so I don't know that we need to mute anything. I think when we're at a point in our course where more participation is great, and this is our second to last session, and we'll have a little bit of new content today, but next session will be you guys presenting the content and reflecting back in the homework assignment what we've covered. So any questions that arise today or through the next week, please let us know. All comments, all questions, most welcome. As usual, we'll review a homework assignment today, and then our assignment for our last session next week is designed to put together multiple concepts addressed throughout the last 4 sessions and what we discussed today. As always, we love to have your feedback. It's super, super helpful for us when you complete the Survey Monkey after the session, and AJ puts those together and tells us if we were on point, off point, what you want to know more of, what you want less of. And if you need to reach us between sessions, please, my email is right there. Happy to engage, answer any questions, have any more discussion, take a look at aspects of your homework assignment or whatever else would be useful to you. All right, been a few weeks, so we'll have a quick recap of session 4. We'll then go over our homework for session 4, and I will pick 2 of you at random. And then the content for session 5 is really building on what we talked about last time. You've now got this network, this integrated care neighborhood, clinical neighborhood, however you want to term it. And now you've got to figure out how you're going to apply tools and techniques and processes and people to manage that. And then we'll have a look at what the homework session is for session 6, your final presentations. So when we met last time, we talked about building health neighborhoods. Now the context for all of this is clinical integration. And we've been talking about the process of figuring out how you clinically integrate. And the answer is always, well, what is it you want to integrate and why? So previous topics have covered things like, what do we mean by medical behavioral integration? What's the difference between integration and co-location? Last time we talked about clinically integrated networks. And there are different flavors of clinically integrated networks from a legal standpoint. For example, a physician health organization is different from an independent physicians association, is different from an accountable care organization. These are done, these types of organizations are set up just as much from antitrust and compliance perspectives as from, the need to meet other business requirements like reducing total cost of care and collaborating, et cetera. And while the legal frameworks behind these different manifestations of a clinically integrated network might differ, their similarities include standard contracting policies and procedures, common measurement frameworks for cost, quality, safety, incentivization and sharing, incentivization to attain whatever business goals there are around quality, clinical quality, patient satisfaction, and then shared infrastructure, in particular shared IT, is one of the easier types of integration to demonstrate to an entity like the Federal Trade Commission or the Department of Justice. The takeaway advice at the end of the day was get a good lawyer and be prepared to spend a good amount of time, especially on data sharing agreements and a structure that lets you make both strategic decisions and process level decisions. And so this time, what we're going to cover is more around, as soon as we get through the homework, we're going to cover more of the kind of process level aspects of governance and integration, how you survive in the neighborhood together. But first, let's pick two of you at random to go over homework. So the homework was really, all right, you've identified a cohort that you want to manage. You've identified what they need from the healthcare neighborhood. Now let's identify who you want in the neighborhood and what kind of a relationship you will structure with them. What sorts of roles you expect them to play, what your thoughts are about compensating them, and then how you will share information. So let's pick on Laura, visiting nursing. How about Laura? Do you want to share what you thought about?
Yeah, I'll tell you, I'm a little not sure how this fits with us, on it. We don't have any specialists to go into, so if you're looking back at, an IPA piece with it, we don't go into specialty pieces with it. We're primary care. We have a few specialists here within it, and we're a federally qualified health center, so, and I'm not sure if that's what all the other organizations are that are on this group too with it. So that's my challenge with that piece, is because in our marketplace and our network right here with it, it would be unrealistic to work with just like one hospital organization with it because of our territorial coverage with it. We cover over 3 counties, and there's different, about 14 different hospitals, and probably about 9 different systems that are in those areas with it. So it's not like we can just network into just 1 or 2 of them with it. However, I think in moving from maybe specialist group or hospital groups, I think the opportunity is there to work with maybe an insurance group. And with some work with this here and learning about this, but also with the a house calls program that I was at a couple of weeks ago earlier this month, they said a good place to start would be with like a Medicare Advantage program where you have a contract in with that. And can work on a small number of patients to work in with to make sure that you're meeting your quality measures, you're getting that integration going on with the IT. That's been a problem for us with our insurance plans here. And I agree with you, and I think some of your comments you've made at my meetings here I've shared with our CEO, because our legal counsel here is very, nobody can touch your system. Nobody can come into and nobody can integrate in with your system. So it ends up being, for my area of a lot of care coordination is what my areas cover with that. We always have this missing piece that we can't make the complete connection going back and forth. And our IT program is GE Centricity, so it's not as robust as like a Cerner or Epic system that's out there. So there's limitations within that piece of it there too. So that's where I'm kind of working towards or looking at. From there, I'm not sure if that meets what you were looking for here with it or not.
Well, that's interesting. The advice you got to partner with an insurance company, for example, around a Medicare Advantage population. So that would be a population that is older and or has some people who are disabled and eligible into Medicare as a result of disability. If you were to care coordinate for a population like that, what sorts of relationships do you think you would need with other providers to improve the health outcomes of a population like that?
Yeah, my thinking is that we're going to definitely have to have some support with some specialists that we don't have here, such as cardiology and possibly nephrology and pulmonology and even rheumatology, with it. So I think there'll be some specialists that you'll have to work around with that. And that's a challenge because our population is typically, with a Medicare Advantage program, it might be something that they're already in the plan that we can start to partner with them closer and do that care coordination piece. And, but the other part of it is that, there's this you got to make this jump at some point.
Yep.
To get into there, that's why it's do you just tip your toe in the water and take a couple hundred lives out of a small insurance plan and try to see how that works and work out the challenges with that group before you get into 3,000?
All good questions. And I think the intent of the collaborative is to be able to start to tease out some of the pros and cons of exactly those questions, Laura.
Mm-hmm.
So, what I've heard you say is, okay, we're on centricity. Centricity makes data sharing difficult. So if you were to work with nephrologists, rheumatologists, what do you think would incent them to come to the table to want to coordinate with you?
I think because of our abilities to care coordinate for a very challenging population, that it will help. We have supports and services that they would not have in their office, and that would be the piece that we could help. Social workers and nurses that can do home visits and really wrap around to get through any of the social determinants that might be preventing that patient from being successful in their self-management with it. So I think that part of it is a good piece to bring to the table with it.
Mm-hmm. What would you expect from them in terms of, access and clinical quality? And
I just spent my lunch hour with a nephrology group and infectious disease group here in Aurora, just talking about specifically of this. It's not necessarily that we're going to be contracting with them, but they had been seeing our patients pretty regularly, and so it's getting that data information back and forth. It seems to be the biggest, challenge with it. So they're not accepting patients until they have the office visit notes and the lab reports. So we have to figure out a way to send that on over to them securely and efficiently, or they have access to our system to be able to get that information. So do you go through people to get that obtained from it, or do you can you automate that some way through your IT system?
Okay.
But that I think that's the piece that whenever you're working with other entities, you have to work through that IT piece, and that's been my biggest stumbling block here. And I don't know if anyone's worked through that, if they've had, our legal counsel seems to be very conservative on access to our system, and yet my staff has access to almost all the hospital's EMR systems. So I know there's got to be some kind of middle of the ground piece that we can work with.
And this is Karen, and we've done something similar to that. So if you'd like for me to kind of share with the homework questions how we tackled it.
Great.
We identified partners of specialty care. We're primary care, and so for chronic disease management, of course, there were many patients that were not getting timely specialty care, such as cardiology, podiatry, and so forth. So we partnered with our hospital, our indigent care hospital, but we also went, I'm sorry. Okay. And then we also contracted with specialists that would come on site to provide care to our patients. And those specialties included cardiology, ENT, and podiatry, in particular looking at hypertensive patients for cardiology, looking at podiatry for our diabetic patients, and ENT with our asthmatic patients. So we were able to have providers, specialists come on site 1 day a week to provide those services as an in-house referral. But then we also worked with our indigent care hospital so that we have a bridge platform that from our EHR to their EHR to provide real-time appointment scheduling with other specialists, GI and the like, where we can actually go into their scheduling and schedule our patients to be seen timely. We get follow-up information that way, and we can actually see if they were able to keep their appointment. The next question was, what roles will they play? They actually became a part of our team, meaning that when the specialists are here at our location, they use our EHR to document because they're our patients. The relationship, I'm sorry. Hey, could you hear me, or did I lose someone? I thought I heard something.
I think we just have a bit of feedback, Karen. You're great. You're doing great.
Okay.
Keep going.
Okay. All right. And the structure is that we have them on site so that it's completely integrated. We schedule appointments for our patient. If someone comes in that day and actually needs to be seen that day, they're able to see the specialist as long as they're already an existing patient, and we have a medical chart for them that necessitates for them seeing one of the providers. The specialists that are on site, there is not a compensation that's provided to them. They're covered through with their time they're giving to us. And so there's no compensation that's provided, and their malpractice is covered through a different agency that supports providing care to those who are uninsured. So in that way, they're able to give their time, and they're able to be covered at no cost to us, but our patients are able to receive specialist care. Data and information that's communicated is we actually get to see the results of their visit in our EHR from when they were seen by the specialists that are on site, and then from when we make referrals to our indigent care hospital through the bridge, we're able to get that information. And have it. Uh-oh. Is that me?
You're doing fine.
Okay.
You're doing fine.
Okay. That information into our EHR, which becomes a note, just like any other specialist that we refer out. Only thing is, we have 100% of getting the information back on the patient by doing it this way. Performance, we're able to determine whether or not we'll look at quality measures for those patients that are in need of specialty care and gauge whether or not it's impacting the management of their disease state. So it's worked out really well for the last year.
How is it that you got these specialists to come on site for no? And so this wasn't part of, or was it part of some value-based contract with a payer that's compensating the specialists, or how does that work in the context of the value-based contract?
Yeah, no, they give their time. Our facility actually started out as a free clinic before the FQ designation, and there were specialists that were interested with us. We have partnered with several hospitals in our area and have demonstrated that we have a need for our patients. So the hospitals, such as there's a hospital that is known for cardiology. It is part of their benefit to community benefit for their providers to do service. So we have a provider that gives his designated day a week that he gives time. So in essence, I guess it's partnership with other tertiary care, other hospitals, but there is no exchange of dollars. And this is strictly for, there's no remuneration that they receive from us. We don't pay a salary. They give their time to see the patients that we have that are in need.
Mm-hmm. Okay. So is there anyone in the group who does, in the context of a value-based agreement with one or more payers, have formal structured partnerships or relationships with other providers requiring some level of integration?
So this is Tracy in Springfield, Illinois, and we just did a pilot for one of our Medicaid expansion groups, and we had to partner with our local mental health center and one of our local large hospitals. And what we did was we took their top 20% high utilizer patients, and between the three of us, we developed an algorithm for assigning them to case managers with different specialties. So my mental health case managers have a little different specialty than the ones who work at the hospital, than the ones who work for my FQHC level. And we identified an algorithm to identify which level of case manager they should be assigned to. And then we negotiated a contract with the insurance company to reimburse us based upon the complexity of the care system that we're providing back. And then our hospital provided the data source and the data collection tool. And I provided the training for everybody plus the algorithm decision-making tool. And then we looked at how we split our profits from there.
Okay. What degree of formality in terms of documentation did you put in place as you negotiated with these other partners?
So we have VAAs, of course, and our MOUs, and then we had our signed contracts that allowed us to, we came up with a signed contract of exactly what data points we would collect and measure, and then what the reimbursement rate would be for the different complexity levels. So we kind of created our own systems, and everybody had to sign off on those. I don't know if that's what you're asking or not. And legal had to review all that, and we had a new consent form signed that allowed access, one consent that allowed access to all three of our systems. And then we had training that was specific for everybody in the three groups that are working together to understand how to utilize this system and how not to, cross the barriers of trying to refer patients to our own system versus identifying what was the patient. So we had training and sign-offs on those.
Okay, great. Okay, should we move on from homework, or do people have questions for any of the presenters about how they structured relationships, how they made decisions about data sharing? Very different scenarios here. Okay, hearing none, we'll move on. Oops, if this will let me move on. Come on, let me move on here. Shoot. For some reason, it's not letting me advance.
You want me to try, Natalie?
Yes, please. Thank you. How come you're here? Okay, so the topic for today is really managing the neighborhood. We think of clinically integrated networks as neighborhoods where different providers of various services, many of them clinical, mental health, social services, collaborate. And we've talked a little bit about governance models for clinically integrated networks. From a legal perspective, last time we talked about articles of incorporation. Now that tends to be more of a what is the legal entity and what are the implications for paying taxes or not paying taxes, for lobbying, etc. So that's kind of the what does the corporate structure look like from a legal entity perspective. Then there are bylaws usually which spell out, okay, here's how we're going to be with each other. They're mostly focused internally, They might set up committees. They might determine membership on various committees. They might determine voting rights, quorums, things like that. But, while articles of incorporation are sort of externally focused, bylaws are internally focused. And those may or may not be accompanied by participation agreements and or contracts. And all of that falls into the bucket of governance. And that's all work to do to set up. But then you get down to the nitty-gritty and you have to start executing. So this time we're going to talk about participation agreements, contracts, less so that, and more about delegation grids. And then the other big topic for the day will be performance management. So as you're kind of monitoring and perking along as a neighborhood, how do you know that things are going well, and how do we all pay attention to our respective roles and responsibilities? Because guaranteed, even though there's integration, there is definition of what's unique to each of the participating entities. And so I think Tracy Smith, Leanne is asking, can you share the algorithm you mentioned? I think that had to do with deciding where to assign high-risk cases. Would you be willing to share that, Tracy?
I probably can't at this point because it's kind of prioritized and owned by the group. But I can tell you it was based upon the number of ED emergency room visits, the number of chronic diseases they had, and the number of social determinants of health using a social determinants of health map that we use, which leads us down to look at things such as trauma, isolation, and other issues like that. So those are kind of the four main pieces we use to develop our algorithm. I'm sorry.
Sorry, Leanne, you're out of luck.
Yeah, that's good. Thank you.
Okay. So, we'll take a look at, how you get into the nitty-gritty of defining specifically who does what when you're integrating to share a pool of patients. And then we'll talk about performance management. Sherry, help. Thank you. So deciding what your SIN needs in terms of, specificity with regard to roles and decision-making and all the rest of it depends on the complexity of what it is you're trying to do from a financial perspective. So we've consistently talked about, pay for performance as one kind of model that probably requires you to look at performance on an ongoing basis and be able to analyze it, report it to figure out if you're going to get paid or not, but probably don't need a whole lot of integration across a neighborhood to do P for P. But when you start getting into bundled payment, there you need a common clinical model. So, if you're primary care and you're working with specialists, or you're, for example, you might be doing bundled payment on labor and delivery. So you're going to need to have specialists in your neighborhood, OBGYN in your neighborhood, potentially hospitals, NICUs, etc. There you're going to need for bundled payment, shared savings, and other arrangements to have a common clinical model. And you'll do that as a basis for being able to document execution responsibilities and monitor performance on an ongoing basis. And then you may or may not have ongoing network management depending on how integrated or not integrated the neighborhood is. So does that make sense? The more financial risk you take on, the more you are likely to need more of all of these elements of governing the neighborhood or paying attention to and managing what's happening in the healthcare neighborhood as an integrated entity. Next slide. Thank you. Okay, so participation agreements and delegation grid basics. A couple of ways to think about these. Participation agreements you might think of as coming sort of more towards the front end. They tend to be higher level. They tend to address, who can participate and under what conditions. So who's living in the neighborhood and what's expected of them as they live in the neighborhood. That's rights and responsibilities and obligations. And then good participation agreements also spell out exit criteria. So if you don't want to be in the neighborhood for whatever reason, what are the terms of moving out of the neighborhood? That's a key piece of integration. Ironically enough, it's about disintegration, but to manage integration, you need clarity about what the exit criteria are. And so responsibilities and obligations might include committing resources, including capital. So for example, a couple of you talked about making determinations about what systems you would use and who would document what where and who's got view access. Figuring that out may require a capital call. Depending on the level of risk you're taking on, your participation agreement might require the establishment of and the management of reserves. For example, in Massachusetts now there are Medicaid ACOs forming, and they have up and downside risk with corridors, meaning you can't lose more than 10%, but you can't gain more than 10% over total cost of care either. And since you can lose money, technically, the state requires that there are reserves to be able to repay in the event of a loss. And you might want reserves for other purposes, investment in additional capital, for example. Responsibilities and obligations in your participation would address things like getting board approval, and other aspects of governance. Do you have an executive committee? Is there a management committee? How involved are your clinically integrated network participants in the actual day-to-day of the entity, or do they just kind of delegate to an executive group? Are you going to hire staff unique to this venture? Or are people in your existing practices going to do this as part of their regular responsibilities? And then what are the obligations to meet agreed on performance targets, at least at a high level? For example, your contract might say the clinically integrated network is going to reduce total cost of care by a certain amount in order to earn gain sharing. What does that mean for participants in the clinically integrated network and their actual performance? That may be something you want to start to put in participation agreements. So that's the framing. Delegation grids, on the other hand, are a little bit more specific. We tend to use delegation grids when we get into the scenario, Tracy, that you described, where you're working with two other partners, you're working specifically on case management, you've got an algorithm you use to determine assignment to a case manager, you probably have case ratios that you have to meet, you probably have timing standards for example, completion of a plan of care or administration of an assessment after somebody's enrolled or become eligible for care coordination. And so that's when a delegation grid becomes very practical and handy. It really describes the nitty-gritty specific and more information, more specific information is better in a delegation grid. The other thing is that a delegation grid is usually about the sort of the clinical block and tackle. Participation agreement is usually more around the organizational level questions. So does the difference between these two types of tools make sense?
Yes.
Okay.
Yes.
Okay, so participation agreements, general framing, how are we going to live together in the hood, and how are we holding each other accountable for who's doing what? Delegation grid or agreement, specifically when it comes to clinical management. who's doing what, when, where, how, etc. Okay, Sherry, help. Thank you.
With these agreements, this is Laura, just had a quick question on that last screen. With these agreements then also, would you be identifying who gets what percentage of any loss, to be covered, or also with any savings that might be obtained? Would you put that in that type of agreement also? Or would that be someplace else?
You can put that in your participation agreement. Usually when you start out a new venture, a new clinically integrated network, you may have some ideas about how that's going to work. And so it may not become formally part of the participation agreement right away. But as you mature and it becomes clear, what sorts of revenue you're really talking about, and that you're happy with the balance, you might, in sort of compensating participants in the clinically integrated network, you might decide to have a mix of cost and quality, and
So would that be like would that be like 1 or 2 years out then, you're kind of thinking?
We try, it's always good to have as much specificity as you possibly can with regard to those types of issues in your participation agreement, but you may not have as much specificity as you need right away. So just kind of plan on revisiting your participation agreements on some sort of on a regular basis, especially as in those early years, you will learn quickly what works and doesn't work and how you really want to incent participation and performance. Does that make sense?
Yeah, it does. It does. Thanks.
Okay. All right. So in order to do a delegation grid, or really any kind of participation or any kind of agreement, you have to know what it is that you're working on. In this case, we'll flow through an example of how to deal with or how to create a delegation grid. So starts with a shared care management model. And Tracy, I'm guessing when you dealt with your partners, you said you came up with a definition of who the high-risk patients were. You came up with an algorithm based on social determinants of health, utilization, what drove their risk, and where you would assign them. And so my guess is you had some kind of model that looked like this, where you all as partners got together and said, right, here's what we're actually going to do.
Correct.
Here's what we're going to work on together.
Yes, you say it so much better than I did.
No, not really. But so, from our perspective, there's nothing magic about all of this. If you want to reduce total cost of care and improve quality and satisfaction with care, these are the kinds of things you do. And especially if you're in primary care, you want to reduce readmissions, you want to reduce non-emergency ED visits in particular. Whether you want to follow up with folks who are in the ED in the last 24 hours, last 48 hours, which ED, well, it depends on, do you have the information to support that? How do you want to staff this? But it requires having some depiction of what it is you're actually going to do together as a clinically integrated network. And without this, it's very hard to get to the next stage, which is, Tracy, what you described in essence. You'll hop me into the next slide, Sherry.
Okay.
Thanks. So here's a little snippet that came from a delegation agreement that we brokered for a particular client. And here you start to get much more specific. For example, you'll notice here it says management of level 1 members, and then a couple lines down, management of level 2, management of level 3. You'll see the staffing ratios. Those are patients or members to care manager. You'll see those begin to change as the levels increase. So the first column of this is, well, okay, so what needs to happen? What's the thing we're dealing with? In this case, we're talking about health risk assessments for level 3 or outreach call campaign to schedule a yearly appointment. These are the things that need to happen on the left-hand side, and those left-hand side items are what come from your clinical model or your care management model, whatever it is you as a clinically integrated network are working on together with your partners. And so then the next column, in this case, this was a clinically integrated network working with a managed care organization. So they used those two columns to figure out who would do what. And you know, management of level 1 members, well, okay, the MCO retained that. They also retained, I think, management of level 2, except for the opt-in, if I'm recalling right. So people who were in level 2 didn't automatically get care coordination, but they could opt in. And the agreement between the MCO and the SIN was that the SIN would take level 2 opt-in and all level 3 and would staff to those kind of ratios. And then you start to see in the note details about, you know, face-to-face in home or post-acute setting after somebody's been discharged. You know, this in particular, the MCO had some contractual requirements and timing standards around meeting face-to-face. Tracy, is this sounding familiar?
Yeah.
You know, there were certain, you know, other types of visits that had to occur regardless of, you know, level and well, okay, you know, regardless of level 1, 2, or 3, the MCO was going to do the call campaigns for yearly appointments. The MCO was going to do all of the members or patients who were eligible for waiver services. So, you know, even though the SIN was taking on level 3, if there were people receiving waiver services, it would revert back to the MCO. You know, then they agreed on mutual care plan revision and updating of member goals. You know, there were particular systems named here. Those systems have particular structures to care plans and goals. And so you can see this delegation agreement starts to get into a fair amount of detail and names out specifically what will happen and by whom. And when we've done this with our clients, usually it's there are some best practices. You know, be specific, be as specific as you can. Manage your versions very, very tightly, because as your clinical program evolves, and you know who's in the clinically integrated network, those partners with whom you're trying to integrate may change over time. You may decide to staff things differently. So delegation agreements tend to be living, breathing documents requiring a high degree of version control as they evolve over time. So one of the things you may want to do with your partners is negotiate a change control process early on to reinforce that it's a living, breathing document and revisit it at certain periods, where you're all still sanctioning it or agreeing on changes. But it's the source of truth literally about who does what. It's helpful sometimes to keep a definitions document. What do we mean by a health risk assessment? Or are we using particular proprietary assessments or commonly available? Is it administration of a depression assessment, or is it the PHQ-9 specifically? So, keep your definition document. We have found it's helpful to have as many of these negotiation sessions in person as possible with your partners. At least start out having these sessions in person so you get to know each other. You develop, there's usually a lot of discussion. It's very seldom that you just sort of are able to perfectly bullet out all the things that need to be done and there's perfect agreement on who does what and everybody understands automatically. So, if you can spend some time with your partners, that helps. And just never forget that. Huh?
Sorry, Natalie, Sherry. The only other point I think I would suggest is that, particularly between a SIN and a payer, that the delegation agreement should support the contract. So you should be referencing the contract as you go through this, because sometimes the contract spells out some of these terms, and they should be in sync.
That's a really good point. A delegation agreement, in this case, it's between the MCO and the SIN. but you might have it between partners in a SIN, and Sherry's absolutely right. You know, whatever participation agreement, contract, etc., it should tie back to it. This is how you're going to execute on what it is you've contractually agreed to do. Okay, so no questions on delegation agreements, general understanding of participation agreements. Let's move on to another important aspect of how you govern and sort of monitor and pay attention of and make sure that things in the neighborhood are going well. So who on the phone has performance management experience? Who's done a lot of performance management, you know, developing frameworks, collecting data, putting together and populating scorecards, looking at performance results and making adjustments. I'm guessing there are a number of you that have done work like this before.
This is Tracy. I've done things like that, but I'm by far no expert.
Okay. I still maintain a lot of this, even though we've had performance management in organizations for a long time. I still think this is more art than science. So you know, the first part of it is, you know, as Sherry said, look back at the contract. What are you obliged to do? What are you obligated to do? And what does that suggest in terms of your outcomes and the work you need to do to achieve your outcomes? So think about measurement at both an outcome level. For example, your contract could say you're going to reduce total cost of care for an attributed population. And a way to do that might be to focus on reducing emergency department visits. So those might be two outcomes. And then you might decide that, well, okay, following up with people who went to the ED is a good process for trying to reduce non-emergency ED visits. So there you've got your outcomes, and you would want to measure, okay, is my total cost of care being reduced? Am I seeing fewer emergency department visits? Am I seeing fewer non-emergent or non-urgent emergency department visits, whether you pick ARC criteria or potentially preventable or some other definition? And then, all right, since you've said following up post-ED to get in for follow-up, is the process or one process by which you're going to achieve that outcome. You probably need to measure whether or not that process is being executed. So think about a mix of both outcome and process measures when you're putting together your performance management framework. Then the next step of all of that is defining accountability for the data. So where's the data going to come from? Who's going to retrieve it? Who's going to put it together and clean it up, because data is always messy? Who's going to analyze it? And then how is it going to get shared among the partners? And then, you know, this starts to get back to your participation agreement or your other organizational level document. What actions do you take based on agreements in those sorts of documents when things are not going as you would like them to go? So that's a big area of work, is to define accountability for the data and figuring out how to retrieve it, analyze it, share it. So then the next step in this is figuring out what scorecards are going to look like. And a part that gets lost a lot is structuring discussions around those scorecards or reports. We sort of tend to say, here's a report. It should be immediately, apparently, intuitively obvious what it says, you know, have a nice day. And we forget about the part that says, okay, let's sit down and talk about what the data means, especially when new reports or scorecards are introduced. So don't forget about that part. It's really important, because otherwise, you know, there will be investment in good work and not many people who really understand how to use it and what to do with it. Information should be thought of as like a basis for decision making. And so what information do you need to make decisions? And then another piece of the scorecard is figuring out, okay, contractually we've committed to some kind of planned performance. For example, a 4% reduction in preventable readmissions. What was our actual performance? So we're comparing planned against actual, because if actual isn't going according to plan, we need to be aware of that and adjust the plan. And then, so that's the basics of sort of a performance management program. Some other things to think about are, you know, as your population changes, and as the participants in your clinically integrated network change, how does that drive rethinking of who needs to be in the healthcare neighborhood? And then there are probably going to be compliance issues, you know, especially around data sharing, data privacy. So you want to give some thought to compliance, especially if you're going to share information across separate legal entities. So those are the basics of performance management program.
And most people probably know this, but, you know, I'm just going to say it out loud, which is, you know, whenever you're looking at outcome and process measures, you have to have the ability to track any of those. And I think sometimes that little component gets lost. It's great when you can agree to outcome and process measures, but it's another thing to be able to collect and manage and determine what the algorithms actually are for all of those. So just another piece of baseline, which I'm sure many of you have experienced, but it's important.
Right.
Next slide, Natalie.
Thank you. Okay, some guidelines in establishing measures. You know, one rubric we've worked with is called SMART. Has anyone here heard of SMART? Come on,
yeah.
Tracy.
Yes, this is Renee. I'm quite familiar with SMART.
There you go. You should describe this.
You want? Okay.
Yeah.
Oh, yeah, no, I use this framework a lot. I mean, really, it's about setting up a way where you can answer whether or not you've achieved your goal with a yes or no answer, right? So you have your specific goal. So instead of saying, I want to lose weight, you would say, I want to lose, 15 pounds in the next 3 months. So specific measurable. So again, you need to have the numbers. You can't just have, I want to lose weight, I want to lose how much weight, and in what amount of time. Achievable. Medically, yeah, it's quite feasible for me to be able to lose 15 pounds in 3 months, and I'm not shooting for something like, 90 pounds in 2 months, or trying to run my first marathon when I haven't even run a 5K yet. So both achievable and realistic and timely. Is this something that I can start now that I have the time and ability to dedicate to achieve my goal? So whenever I'm working with my staff to have them work with their clients, basically the goal, you should be able to ask, have you met your goal? And the answer should be yes or no, and not really any wiggle room or gray area or hemming and hawing around it.
Right. And so in this case, Renee, you brought up some definitions here. They're a little bit, you talked about the A as achievable, in this rubric, actionable, is it clear what the desired behavior is? For example, run a marathon or, reduce ED visits within 6 months. Is it clear what it doesn't mean, is what we mean by actionable. Renee, you talked about the time bound by when stuff must happen, but I think your guidance around being able to ask the question and have like a yes or no answer come back is a really good litmus test for any of this. So there are lots of common measurement pitfalls. I just picked 4. And, maybe lessons learned is a better way of saying it. I don't know. But let's talk about them. So, first of all, it can be very easy to have a lot of measures, especially when you have new data sources, you're excited about a new program, you've got new people in the mix working together, you don't know how things are really going to go. There's a temptation to measure everything. And that's generally not a good idea for a couple of different reasons. One, you won't necessarily take action on every piece of data. There's a difference between, information that's sort of nice to know, but when it costs, time, money, people, whatever, to get information, you're going to want to be as precise about how it will be used in decision making as you can, because, it's expensive. And, safety net organizations aren't exactly known for, being the Trump organization with lots of money. So, don't gild the lily here. And don't let yourself get sucked into analysis paralysis because there's just too much to look at, such that you're going to incur the cost to get it, but not be able to use it. So Renee, when you did this, I don't know if you bumped into that trap or how, any words of wisdom in maintaining a discipline around the right number of measures?
I think with my staff, we'll go ahead and talk about examples, and really we kind of role play what the process will look like. And I just continue to work with them and give them guidance on how to ask questions and the difference in how we can use open-ended and closed questions, and getting to that end point of, did I meet my goal of being a yes or no? So I think once you have the framework and you're comfortable with it, it's there. And I think it's just a matter of talking it through and practicing to have the familiarity to implement a SMART framework.
Okay, so a second pitfall is mistaking correlation for causation. So, and that gets to kind of a program design flaw potential. So oftentimes in performance management, we're making assumptions. We assume that if we give everyone wallet cards that have an after-hours triage line, we extend, availability for appointments into the weekend and a couple of late nights, and we relentlessly follow up with people who have been in the ED no later than 36 hours. If we do all of those things religiously, we will see emergency department visits drop. Those are assumptions. And so we make those assumptions eyes wide open because there is a correlation between those sorts of activities and reduced emergency department use. In that case, maybe you could suppose that, yeah, doing those activities is the cause of reduced ED admits, but there may be other factors. So before you decide to you pilot something, you test what you think might work, you figure out how to scale it. Still always be mindful of the difference between correlation and causation. So for example, if you were to do that emergency department study as a pilot over the late summer, early fall, there's no flu season. Kids are going back to school. Maybe they're more likely to seek, annual wellness visits, have reminders from the health plan or whatever. You could naturally, as a result, see other reasons that explain the drop in emergency department visits. It's not flu season. Flu shots are being messaged. Preventive care is being messaged because it's the start of school. So don't mistake correlation for causation. It doesn't mean don't measure both the activities that you're doing, the strategies that you're using to get the outcome, but it just means be mindful of it. Because you can expand a program to full scale based on small sample size that ends up being kind of faulty. Any questions about that one? Okay, so for example, there's a high correlation between driving a small red sports car and speeding tickets. It does not mean that if you drive a small red sports car, you will get a ticket. Driving the car is not the cause of the speeding ticket. There may be other factors at play, like, I don't know, a midlife crisis, peer pressure, I don't know, but not the same thing. So just beware. Being opaque or vague, you know, to Renee's point about being able to answer yes or no. So ignoring one or more aspects of SMART measurement. Another area where opaque or vague can get you in trouble with a performance management framework is in the data itself. So, and especially when you present the data to stakeholders. So, you know, often when we're presenting data and we're looking at practice pattern variation, for example, providers with attributed patients with low back pain and the use of MRIs or expensive diagnostic imaging in an episode of care for low back pain. And we'll see kind of a curve where some providers, you know, the total episode of care for low back pain doesn't cost a lot, and they're not using a lot of expensive diagnostic imaging. And then there are going to be providers in the middle where, okay, the episode of care costs a little bit more, but imaging isn't such a big part of it. It's a relatively small part of it, you know, and you'll get a whole mix of results all the way to the other end where the episode, low back pain treatment, is expensive and there's a lot of MRI utilization. And then you get to the provider and you say, well, you know, interesting practice pattern, you know, this is the outlier. Everybody always wants to know who the outliers are. And, you know, when you reveal who the providers are or the practices are, they might say, well, my patients are sicker. I have the more complex patients. Or the data is bad. So, you know, the more you can engage stakeholders and your clinically integrated network stakeholders in particular around data quality, sources, definitions of measurements, meaning of reports, the less likely you are to suffer from the results of opaque and vague. When things are opaque and vague, people don't necessarily know how to behave. There's a saying, you know, be careful what you measure. You will get what you measure. So be careful. Being opaque or vague has the other effect of, you know, not necessarily guiding what it is that is expected in terms of performance. And that sort of ties to the last one. The minute you start using results in a punitive method, you'll get a lot of pushback, and you will get into endless conversations about how spotty the data is, how old the data is, and how the analytical methods aren't valid. So that's a really complex one in managing your clinically integrated network and working in an integrated way with your partners. Straddling that line between holding people accountable for performance, but without making it punitive. Questions? Renee, do you have other common pitfalls or advice for folks that are getting into the performance management work effort?
You know, I think for me it was a really natural time to kind of tie in and remind people about their motivational interviewing skills and a lot of solution-focused therapy. And, you know, depending upon the skill set and the scope of staff, there might be a need to provide education in terms of what's, you know, realistic and timely and achievable within a certain time frame. But I think the biggest, you know, kind of piece of advice that I've had in helping my staff be successful is really just having them practice that on me so they can get comfortable with it, and then continuing to check in with them. You know, what are some of the SMART goals that you worked on with your clients this week? You know, is that specific? Is that measurable? And kind of going through each piece by piece and helping to refine where needed. I think it just takes a lot of hands-on practice, but it's well worth the investment of time and energy.
And this is Tracy. I think the biggest point always brought it home to everybody was when we talked about relevant, asking the question, will this help us get where we want to go? And being able to articulate that point led many people to eliminate things they wanted to measure or to think differently about things they measured. So I really that piece.
Yeah, and I think you just made me recall something. This is Renee, and I think having biofeedback is such an important tool for us. So again, if we go back to the example of someone wanting to lose weight, well, in order to support them in whatever intervention or tool they've decided to use, we need to know if it's working. So whether it's weighing someone every week or checking their blood pressure or checking breath CO, to be able to have that actual data to show someone, hey, this is working out really well. You did a great job. You went on 3 walks last week for 30 minutes, and look at this. You're making progress towards your goal. Or maybe it's just a check to say, hey, it looks like you haven't really lost any weight this week. Did you engage in your interventions, or maybe it's that new med you started and you are experiencing some weight gain side effects. I think by coupling the SMART goals with biofeedback and utilizing motivation or interviewing, you have a really great kind of combination of tools to be client-centered, but also to have have adequate data to see if people are moving the dial on working towards their goals.
Right. In the case you mentioned, leads to confusion about how to behave. You've defined specific interventions. And you've determined that they're relevant to meeting the goal. I think your point about motivational interviewing is a great one. And it brings home the point that, performance management, while we're talking about it in the context of managing a clinically integrated network where you have legally separate entities potentially that are trying to work together to achieve specific outcomes, the approach can work in lots of different settings, including how you deliver case management and care coordination services too. Okay, other questions about performance management? We went over it at a high level quickly. There are pitfalls. It is, in some respects, more of an art than science. How many is too many? What's enough? What are the right ones? But don't let perfect be the enemy of good enough. It's just fine to start small and grow it. And it will be essential to how you manage your clinically integrated network and how you all communicate as an integrated entity or a healthcare neighborhood. So, session 6 homework. We'd like for you to create a mock partnership agreement as your homework. So if we play out the scenario, your board has authorized participation in the creation of a clinically integrated network. So you are going to embark on that wonderful journey with other practices, entities. You decide what clinically integrated network means to you. But you're going to have to play nice in the sandbox or manage the neighborhood or whatever your metaphor is with others. So you've done your analysis of data. You've identified your cohort of special patients that you want to manage. You've used their needs to figure out who needs to be in the neighborhood if you're going to achieve better outcomes for this particular cohort. And your payers have agreed to upside-only shared savings based on reductions in emergency department and inpatient use. And so your next step with these partners is to frame out agreements with them. And we'd like you to try and use this grid here just to practice some of the concepts here. So the components are, who can participate? Okay. Who's going to be in the neighborhood? And under what conditions? What do they have to agree to do? When can they no longer be in the neighborhood?
Okay. Okay.
What sorts of things do they need to be able to do? What are you going to expect them to do? What will you offer them in terms of performance incentives? And what will happen in the event that there is performance less than or lower than what you need it to be? So we'd like you to think about your clinically integrated network. You've just gotten your board approval. And if you were structuring an agreement and you looked at these components, what would you want to be in that agreement and for what reason? So, we don't want you to spend hours and hours and hours. This is the bones of an agreement. Does this make sense to people as a homework assignment?
Yes.
Okay. And for those of you that are team captains, the difference will be next time instead of picking on one or two of you, we're going to ask each of the team captains to have somebody on their team that presents this, and then we're going to discuss it as a group. The idea here is for you to be able to practice putting together these agreements where you have to think about entities that might not be part of your legal structure today and what it is you're going to do to lay the framework for getting along in the neighborhood together. So I think contract tends to be more onerous and serious sounding to me. Partnership agreement has sort of a lighter, maybe a little bit fuzzier, but we think that if you can write a partnership agreement, you can probably wiggle your way into a contract. But, start with a partnership agreement. It's potentially a little less scary. And these are the elements we'd like you to think a little bit about. Sherry, you want to add anything? Any guidance?
No, if folks get stuck, let us know during the course of the week. We are meeting. There's 1 week, right? We meet again next week. So.
Yeah, short time between sessions. Questions, concerns? Everyone completely gone to sleep? Oh no, we lost everyone.
No questions.
This is Laura. I think this looks reasonable with it. I'm going to give it my best shot.
You can do it, Laura. You can email us. You can call us if you like. Renee has asked a very good question. That is, how should we access the PowerPoint template for the homework assignment? AJ, what can we do to get this grid out to people?
It should be available for download in that file section. If not, I'll send out a follow-up email in a couple of days, probably tomorrow or the next day, and I'll send out the PowerPoint to each one, all the team captains. So that should be okay.
How about if I just put it in a Word document and send it to you, AJ, and then you can get it out so folks can start working on it right away, since the time is short.
Perfect.
All right. I'll email it to you right after this.
Thanks. Renee, does that work?
Yes, it does. Thank you.
Okay, so team captains, get your teams organized. You've got a week. Our last meeting is a week from today. Laura or anyone else, you get stuck, holler. Please holler. That's what we're here for.
Maybe when you send that out on the Word document, resend out your email or phone numbers with that so that I know who I'm getting in contact with.
Absolutely.
Thanks.
Okay, and AJ has given us a reminder. Please remember to complete the survey after the session, the Survey Monkey. It really does help us, and it really does help the SNAC as an entity. You know, I think SNAC aspires to do more of this type of work. So, you know, we've learned a lot from these sessions and you know, how to structure them. Your input is really, really valuable. So we'd love to have you complete the survey and tell us what you like, what you didn't like, and what suggestions you have for making it better. If not, you get 10 minutes back in your schedule. Have a good week. If you get stuck, call us.